A while back, my partner and I responded to a high school for the report of syncope on the football field. Practice was going on and one of the coaches had fainted. In checking him out, my partner found the coach was 55 years old, had felt weak and lightheaded, and thinks he just got overheated out in the sun. His vital signs were normal, and the coach was only complaining of residual weakness. I'm Angry Bill, and this is Prehospital Wisdom. Here we explain medicine as it relates to how medics and EMTs operate and what they need to know to be successful. Do all the YouTube stuff while I go on with the story. Back to the football coach. We put him on the monitor, of course, because he was old and fainted. My partner hit print and got this. Sinus at 80. It's hard to tell anything else from that view. My partner was very worried about the inferior ST depression. I finished putting the precordial leads onto the patient. The 12 lead that resulted, cut down for privacy, of course, looks like this. That is more complete, so I can say sinus at 80, normal axis, normal intervals, no ST, T-wave changes, or ectopy. Take a closer look at the two EKGs. First, the third beat of lead 2 in the print view does look like there's inferior ST depression. Now look at the second beat in lead 2 from the 12 lead. That depression's gone, or at least much less concerning. Do you see the difference? What caused the difference? Did the patient get better? The printed view has 1.5 or 2 millimeters of ST depression. In the 12 lead, though, the depression is gone. Maybe there's 0.5 millimeter depression in the 12 lead, but there isn't much. What caused the difference? Filtering, that's what. So let's talk about that. Badly. Bear with me, I'm an idiot. You're the one that clicked this video, so you just gotta bear with the bad description. The signals collected by an EKG monitor are very small. The heart's electrical signal is around 1 millivolt, and many waveforms are much less than that. So the EKG signal can be easily drowned out by other noise. The extraneous signals can be from other muscular movements, nearby electrical equipment, nearby power lines, poor electrode-to-skin contact, and from equipment in the monitor itself. The collected EKG signal must have the extra noise filtered out so that a clean picture of the heart's electrical activity can be shown more clearly. In short, noise is artifact. We've all seen artifact, and so thus we've all seen noise. I need to take a minute here and explain that I'm a little embarrassed. You see, my plan for this week's post was to explain how EKG filtering works. So I spent all week researching the topic and failed. I failed miserably. I don't understand the technical aspects of how filtering works on an EKG, even after all that work. Good luck to you if you want to get into the specifics of signal filters. If you can understand the topic, understand it, not just regurgitate it, and you're a better person than I am. If it's something that interests you, to read about log scales, low-pass filters, Fourier analysis, superposition, and phase distortion, then knock your bad self out. I will link the articles down in the description. All they did is confuse me and make me feel dumb. So now I am sad and dumb at the same time. No one wants to be sad and dumb both. Here's what the average medic needs to know about EKG filtering. There's a difference between the print view and the 12 lead. By the way, the screen on the monitor shows the print view. The 12 lead is diagnostic. You can make decisions based on a 12 lead. It's the same view as on a 12 lead in the hospital. Same thing cannot be said for the print view. The monitor screen or the output when you hit print is not diagnostic. Don't make decisions based on what's printed if it isn't a 12 lead. Look at the bottom left of the printed EKG and the 12 lead above. The print view is filtering at the 0.5 to 40 hertz level. That is, there's more aggressive filtering going on to smooth the waveforms and rid the EKG of artifact. That filtering, though, can do weird things to the ST segments like, say, depress them by 2 millimeters. Filtering is why you can't print 1, 2, 3, change your view to print the augmented leads, and so on. You can't create a 12 lead that way. It's not the same as pressing the 12 lead button and then getting the results. The bottom left of the 12 lead shows that the filtering is being performed at the 0.05 to 150 hertz level. This is a diagnostic view. It's going to result in more artifact, more baseline wander, and general noise, but it's also going to give you an accurate view of the patient's heart's electrical activity. ST segments are accurate at this level of filtering. In order to cut down on the noise in the diagnostic, nearly unfiltered 12-lead EKG, we have to be very precise with electrode application, electrode location choice, vehicle movement, patient movement, all those kinds of things. We have to make physical changes to improve the quality of the EKG rather than relying on the monitor to filter out the noise for us. One way or the other, make sure that you are making decisions based on a diagnostic level view of the patient's EKG. It would be pretty embarrassing to STEMI alert a patient based on falsely elevated print view ST segments. Let me know what you think of this. You can comment or send me an email to the address in the description. If you found any value at all from this video, click the like and subscribe. One of the most helpful things you could do is share this content with someone you know. Click over here for another video, or click over on this side for the channel page and all videos. Subscribe's a button below, and I'm trying to hit 1,000 subscribers. I'm Angry Bill. This is Pre-Hospital Wisdom. Until next time, stay safe.